Okay, so welcome. So today we will do an introduction to pediatrics and obstetrics because they are related topics. And yeah, so then we start with puberty physiology, but we will only cover the physiology part, not the pathology, because it will take too much time. Okay. So yeah, this is recorded. So if you have any problem with recording, then just don't participate. But it's also an interactive seminar. So there will be some questions, and the faster you answer, the more fast we will finish. Okay. So it's like the physio thing, like a seminar, interactive. Don't be scared to try to answer because this is how we learn, right? I'll give you about 10 seconds to think about it, okay, for every question. And yeah, and I will give you all the PDFs of the presentation later on, okay? You can study on your own time. There will be a lot of information in my presentations, but I will not just go through them now. I will give the presentations and you will go through it on your own time, okay? So here we're just gonna learn what is going on, okay? So the basics for it. Okay, so let's start with the basic introduction. Okay, so for pediatric state exam, what is different is that you will have to know your anthropometry, okay? So anthropometry means the values of your body, like height, weight, and how they change as well. So the growth rate, okay? So anthropometry is a must, and it's different for every year, every age period. So you have to memorize one paper, and for every disease, they will ask you about it. So what you have to do once you go in the class, you need to be at the level of being able to write all the anthropometry in 2-3 minutes, okay? So no matter what questions you pick, the first thing you do, you write your anthropometry. Then you start to prepare for your answer, okay? Because they can jump from one age to a different age. And if you don't write it down, you will confuse it in your head. And they are very picky on it. So if you have the paper, you can look at it. It's better if you don't look at it. You show them that I memorized it. You know, it's better not to look at it, but it's good to have it there as a backup. Okay, so you look at it. Don't confuse yourself. That's why the first thing you do is put the anthropometry on the side. Okay, anthropometry changes between countries, and every country updates it every 2-3 years. Okay, so what you will memorize, it's only useful in the Czech Republic. If you go back in your country, you will see that the numbers are different. Okay, so this is something which is very sad. You're memorizing some numbers only for Czech Republic, but we're here to pass the exam and get a diploma, okay? Another important thing for pediatrics is that the signs and symptoms are specific to your patient, okay? Your patient has a specific gender and a specific age as well. So what Professor Honzik likes to do, and Professor Zeman, is that they ask you to name your patient to be on the same page. So they would tell you, okay, you have a patient, his name is Honza. He's a boy, he's 5 years old. So tell me everything about him. So when you go, for example, a disease will cause tachycardia, in internal medicine, you can say, oh, my patient has tachycardia. But in pediatrics, they don't want you to say in general tachycardia. They want you to say, Honzik, 5 years old boy, will have so much beats per minute, his heart rate. Say the number, like 110, for example. Okay, so you have to say the exact number. Why is this important? It's because the ranges, you remember in physiology, there is some ranges. So the top range and bottom range, they keep moving with age. So in the beginning, for example, the value 90 might be a pathology, but then as age progresses, it will become normal physiology. So because the values and the ranges are moving, you need to have everything written down in anthropometry. You can see the age and you don't confuse yourself. There is even more details, how much they increase. For example, for every degree of fever, the heart rate increases 10 BPM. So if the value, the upper limit is 100, and you want to say tachycardia, you will not just say, okay, I know my upper value is 100. You will not just say 110, 120, like something above. You need to say exactly how much is increased. You will say my patient has 2 degrees higher fever. So instead of 37, he has 39 degrees of fever. And then this means 20 BPM. So minimum from 100 will become 120 minimum. And then he has also inflammation. He also has pain. This will also increase heart rate from sympathetic system. So if you say something less than 120, that would be wrong. Even though it's tachycardia, which is above 100, it's still wrong. So you need to calculate exactly how much. Respiratory rate increases 2 to 3 BPM per degrees Celsius. So even that one needs to be calculated. That's why when you go there, make your anthropometry, write down your patient, age, gender, okay? What are we looking at? What is the disease? See the symptoms, and then start calculating. So what I like to do first is look if there is any fever. I start with the fever first, okay? Then you look if there is some dehydration, because dehydration also makes, the signs and symptoms of tachycardia. So yeah, the thing about pediatrics, you need specific signs and symptoms for your patient, name your patient, the gender, the age, and then have your anthropometry next to see what changes, okay, from the disease. Now, there is different examiners and they have different types of examining. That's the problem with oral exams. It's not standardized. So we have different professors. They like to examine on different things. So when we study, we try to prepare for all of them. So one examiner, I will not say names, okay, just one examiner likes for you to know one disease very, very well. So minimum 15 signs and symptoms. So to be safe, you just memorize 15 minimum, then you can make up to 20 or 25. You can make it up using logic, okay? But the examiner will go there. You will tell him, I have the question of puberty problems. He will tell you, okay, choose one disease, which is very common for puberty problem. And then he will tell me everything about it. So we're talking again, numbers, okay? Not tachycardia, exactly numbers, okay? Not slower length, smaller height, the numbers, okay? Say the numbers. Yeah, so this is the first examiner. He will ask you one disease, you start talking about this disease. Once you're done, he will tell you, okay, you know what, let's go to the next question. So for this examiner, you should know one disease very, very, very well. Another examiner will want some theory on the topic, okay? And then he will tell you, choose 3 diseases you know well. And then if you are very well on the first one and you spend some time on it, the other 2 will be just basic or he will just skip it altogether, okay? So again, if you know a bit of theory and one disease very, very well and you show your confidence, he will say this student knows his things, so let's just skip the question. So the exam is a bit fast. He will not stay there for 10 hours examining you, okay? Even though he will ask you, tell me 3 diseases, if you are very well on the first one, he will just skip the rest, okay? So again, one disease you should know very well. What happens here and why many students have problem with this second examiner is that they don't choose the most common diseases or the most discussed diseases, okay? So for example, Professor Honzik, he likes a lot the metabolism. The diseases of metabolism are very rare, but we have the Center of Metabolism in Czech Republic here in our faculty. So he sees them every week, even though it's very rare because it's centralized, okay? So even though it's not the most common, it's the most discussed, it will be in his lectures. And also you can see some notes on the exams, what they were asking before. So when you go there, if you choose 3 diseases that he doesn't like, that are not common, and he didn't discuss them, he will, even if you know the first one very well, he will tell you, no, I don't like your first one. Let's talk about the third one you mentioned. Or let's talk about the second one you mentioned. So try to name 3 diseases which are common and discussed, and try to think which one do you think he will be most likely to choose, or what was he asking in the previous exams, okay? This way you will learn that one very well. And when you start talking about it, he will say, yeah, that's a good disease. Let's talk about this disease. Your choice was very good. And then the last professor, again, he wants some theory, like most theory. He will ask you a bit of pathophysics. It's the only professor who goes a bit more details on theory and pathophysics. And then he just wants the basics, like tell me 1, 2 diseases from each age period just to have the basics, okay? Remember, each patient has different anthropometry, specific signs and symptoms, and for the same disease, it manifests different on each age. If it's a young children, it has different symptoms than a teenager because they are going through different phases of their life, okay? Yeah, so that's it with your diseases. And coming to like a summary, let's say, the way I was preparing for my exam, and I was gonna write down on my paper. I would get one paper, write down all my anthropometry. So this is your paper right here, your first paper. Okay. The first thing you go in the exam, write down your anthropometry. The faster you are, the most efficient you are, the more time you have to prepare for your questions. Okay. So what I was doing for my questions is that I had a small introduction of theory. So that's your theory over here. Okay. So your theory, it's understanding what we will be discussing today. So each topic has a bit of theory inside. As we said, like fever, it changes the heart rate like this. It changes the breathing rate like this. So when you speak about the question of fever, you can speak about the theory, maybe a bit of pathophysiology, like interleukins, prostacyclins, and how it affects the fever, like a bit of theory, just an introduction. And also in this part of theory will be your definitions as well. What does it mean febrile? What does it mean subfebrile? What does it mean hyperpyrexia? So that's your introduction. Have a small introduction. As we said, one professor doesn't care for this. He just goes straight to the disease, and he will ask you the theory inside your disease. So you will say, my patient has 39.5 degrees Celsius, and he will ask you why. What is the definition of hyperpyrexia? What is the definition of febrilia? Okay. So the professor that goes with the disease also has some theory inside, but it's during discussion of your disease. Okay. So how I was preparing for it, like the diseases you have to memorize, right? It's this part over here. This is just to memorize. I will send you my notes if you want. There's a lot of information, but I didn't memorize all of it. I just have it there, and I was highlighting what is good to memorize, okay? But the theory is just understanding. Once you understand it, the only thing you have to memorize really is the definitions, okay? And then for the diseases, one disease, very well. This one over here. Have one disease for each question very, very well. That's your Zeman disease, okay? Find what disease he likes and learn as much symptoms as possible, and try to have like a bracket next to it and say logic, the things you will not memorize, but the things of logic. Yes, a question?
Do they care incidents per se, or just the
Depends on the professor, on the date, and on the question. So some questions they will ask you, for example, some tumors. They like to know which tumor is most common in which age. Okay. For me personally, they didn't ask because I didn't get a question that required incidents. I had one question like with theory. So I spent a lot of time on theory. And then I had a question about differential diagnosis. So I just started classifying it and spent a bit of time in classification. And then he asked me, okay, let's go into clinics. So he went down the clinical path. He told me, you have a patient, this is his age, this is his gender. He comes to you with this problem. What do you do? What could be the causes? So then I already written the classification. So I went back to the classification. I was like, okay, it could be these 3 types of diseases. I want to use my ultrasound first. I want to use my labs. I want to take the history, see something from the history. Yeah, so I went down the clinical way of asking, and then finally ended up with what could be the causes. So that was my differential diagnosis. It goes down the clinical path. My theory went down to the definitions and some symptoms and based on age. And my second question, I think I mentioned the incidents by myself. I was not asked, but I mentioned it. Yeah, I think it was like Epstein-Barr virus and infection mononucleosis. So I went down the symptoms of it and what ages manifest and what is a differential diagnosis for it. What is it confused? So I went down the infection mononucleosis pathway. So there was no, I think the incident I mentioned it by myself. But I know some people that they were asked. So like, but most of them, the important ones would be 1 to 1,000, like very common, you know. So try to memorize the most common. Don't learn the ones that is 1 to 120,000, unless it's metabolism specifically for Honzik. Okay, these diseases he will tell you in his seminar. So he will do a seminar and he will tell you, for this question, I want these 3 diseases, and he will tell you the basics for it. So these ones, you should know the incidence, even though it's rare. Okay, the other diseases it's very easy to memorize because the number is small. 1 to 300, 1 to 1,000, 1 to 800. So that's the common diseases. Don't memorize the like crazy diseases 1 to 25,000, you know, unless it's very important and it's discussed. Okay, so that's what I was doing. I kept the numbers small, kept the diseases common. So when I talk about them, they say, yes, I actually see 5 of them every week. So it's something they like to discuss. Okay, if you say something rare, they do see it because we said we are centralized. But if it's rare and it's mentioned in the seminars, you should know that as well. Like 1 to 120,000, something like this. So it's always a ratio. Okay. And also you can just go like general. If you don't know, just say most common in this age, most common in this age. So you can go like this. Yeah, personally for me, they didn't ask me. And then I said, I have one question very well. That's my Z-man question. Okay. Then I have 2 questions which I know well. So in case they don't like my first one, like Honzik or Magner or someone, I can just jump to my plan B. So that's my plan B. Yes. And then I have like 4, 5, like the 4th and 5th. That's just basics. Just know 6 bullet points. That's the knowledge from your USMLE, your knowledge from internal medicine, just basic knowledge to know what's going on. But when you go to the exam, you have to act confident as if you know everything very well, okay? So don't panic, keep your confidence and don't let them know that it's you know only the basic, okay? So make it seem like you know everything as a red color, but it's impossible. The time we have to study for this exam is too small for the amount of material. So know for sure one red, one very well. That's your Z-man question. Know 2 of them, the second and third, most common and most discussed, well. So you are able to talk about it and show your confidence. And the rest, just the basics, okay? So that's how we prepare for the state exam. Yeah, definitions. Okay, now we're starting our seminar. Any questions like from the chat? Do you have any questions? Do you have any questions here until now?
About specific for the patient, right? What do you mean like that? Because you have a case report in the exam and it says on draft that in the patient or something.
Okay, so the question for online people is that, again, it's a question about what does it mean specific signs and symptoms, right? So why it's moving? Okay, so specific signs and symptoms. This is what you're asking.
So is that a specific case report in the exam or?
Okay, so they will ask you one example. I'm giving one example. Lobar pneumonia. Okay, they will tell me your patient for lobar pneumonia. It could be any age, right? But they want you to know the most common. So lobar pneumonia, what does it mean lobar pneumonia? That it's concentrated on one lobe and that it didn't spread to the whole lung. Okay, so this means that the patient has a very good immune system and is able to keep the infection there, localize the infection. This is impossible in newborns. They don't have very well immune system. They are just born. They need to be stimulated, okay? So if you say lobar pneumonia, my patient is 3 months old, he will tell you, okay, it could be, but it's very rare. So I don't like that one. Choose another age. So for me, if I was asked lobar pneumonia, I would say 10-year-old child. Already his immune system is very strong. And what is the most common? Like some aspiration. So where does it go? Down the right lower lobe, as you know, from the angle of the lung. So you will end up saying, my patient is 10-year-old boy and he has these symptoms. So that's what I mean about your patient. So they will not create it for you. They will not tell me 10-year-old patient. But you will be able, and you should be able to understand what age we're talking about just by the disease. I mentioned before, Epstein-Barr virus, like kissing disease, infectious mononucleosis. I would say most common, it's a teenager, and I will go down the teenager way. I will not say infectious mononucleosis in a 2-month-old child. I would just go with a 16-year-old girl who went on a camping with the school. He kissed someone over there, and then he came back after, I don't know, 2-3 months, and now she has all the symptoms of infectious mononucleosis. Yeah, so the disease manifest most commonly in a specific age, gender, your risk factors. Yes, so you go down that way. Another example, I have a drug addict, a child which is abusing cocaine. I will not say 4 months old or 1 year old. I would say as a teenager, he's 17 years old, he goes out with his friends, and now his hands are full of needle marks. He has withdrawal symptoms, some seizures, So your disease, you should know where does it manifest, and then go down that pathway. In your differential diagnosis, you have to say for each specific age. Okay, that's symptom-based, going backwards. So yeah, like your disease will finally end up explaining you what age and gender. So know your risk factors, causes, okay, etiology. And for each age, you should be able to mention the different signs and symptoms for the specific disease, like in general. The hell is going on with my... Okay. Okay, so now definitions. Can you stop? Okay, let's finish this fast so we can move on to the next slide. Hopefully it will stop. Okay, so what is obstetric and what is pediatric? Do you know? You have no idea? You never heard this? Okay, so obstetric is when you're born, and pediatric is?
It's from when you're born to 18.
So you said obstetric is from when you are born, and pediatric is from when you're born again. So it's the same thing?
It could be part of it. I'm not sure what that's the thing.
Okay, does anyone in the chat want to guess what is obstetric and what is pediatric? Okay, from here, who else wants to try again? Around birth? So around birth, you mean before and after? Sean is writing something. Okay, so let's wait for the chat up here. Obstetric deals with maternal factors, pediatrics in development and growth. Okay. Yes, a bit correct. Okay, so basically, obstetric, as you said, it has something to do with pregnancy, right? So the doctor for obstetric is also the gynecologist, okay? When there is pregnancy, there is two patients, basically, the baby and the mother, okay? So the mother will go to this doctor with a gynecologist, and he's also responsible for the pregnancy, okay? When we go into the surgery, for the mother to come out, like the labor, when we go into labor, the doctor will try to make the baby come out, okay? Once the baby come out, we have two patients, but they are finally separated, okay? So what the doctor was up to this point following the pregnancy and following the woman as well, has to stay with the woman, okay? So he will continue after birth with the woman. That's your obstetric, okay? The doctor. But once the baby is born and detached from the mother, we hand it over to the pediatrician. So the pediatrician is responsible from birth, from the moment you separate them. And the specialty specifically for that period is called a neonatologist, okay? That's your pediatrics. And do you know in Czech Republic until what age is the pediatric doctor? You saw the answer. Okay, so in a lot of countries it's 18, but in Czech Republic it's until 19, okay? That's important for insurance. You have to memorize the schedule of when you go to your pediatric visits. In the beginning, when you're born, you go every few weeks, then it becomes every few months, and then it becomes finally every 2 years. The final visit you're going to do following this schedule is 17 years old. And then comes the question, should we have another one at 18 years old and finish covering at 18-year-old? Or let's follow again the schedule every 2 years and from 17, go to 19. And the Czech Republic, they said, you know what, let's just cover everyone until 19, have the last visit at 19 years old, continue with the schedule every 2 years. So it's 17 and then 19, and then you're no longer pediatric. Okay, so you should memorize your schedule. schedule of visits. So it's very easy once you see the diagram. Maybe we can do it together in another lecture. This is what I was talking before. You have here your gyne doctor. He's following the mother. Then the mother becomes pregnant, and he keeps following her. Okay, he's responsible for her and the baby. Then you have the birth, and then we have two patients. That's your kid. It's going to go with the pediatrician. Okay, and that's your woman again, and you continue with the gynecologist. That's why the specialty is called obst and gyne, right? Gynecology and obstetrics. They go together because you don't know when the woman will become pregnant. You should know the diseases as a gynecologist. So that's your gynecologist. He's also your obstetrician, and he follows the woman the entire way, before, after birth, pregnant, non-pregnant, all the women, okay? But your pediatric will start from birth. Once the baby is detached, he will get the baby and he's responsible for it. And he will follow it all the way until 19 years old, okay? When we do pediatrics, we also have to take the history of the obstetrics. So he's not responsible for it, but he has to know the history before. Okay, so we need a multidisciplinary team. We have to cooperate with a gynecologist, but we are not responsible for it. Okay, we need to know the history to be able to make the best treatment, but we're not responsible for before birth. Okay, that's your gynecology. Yeah. Okay, then we have to divide the periods. Okay, there is different obstetric periods and different pediatric periods. So before birth, after birth. Do you have any idea how to classify them? Yes, you know, but but you don't think of it. Okay, let's go first with the first question, which is how long does a pregnancy last? This is what they ask in obstetrics. How much?
39 weeks.
Can you say again, Victoria?
39 weeks, 40 weeks.
39 weeks. Okay, 39 weeks. So okay, so what they like to do in obstetrics, okay, in gynecology, is that they will tell you in the movies, whatever, all the schools, they tell you the pregnancy is 9 months, right? But then the question is, but the months they change, right? It can be from 28, 29 days until 31. So what does it mean 9 months? We have to be very accurate on it. We cannot be, okay, someone was became pregnant in February, which is less days, and someone got pregnant in June, which is like different days. That's not accurate for us. So what they like to ask is, it's basically 10 months based on the moon months, not the calendar months, but moon months. So if you say months in obstetrics, you can say 10 moon months, okay? Or to be accurate, that's 40 weeks, okay? That's your 40 weeks. But in obstetrics, they have to put a bit of as a range, right? Not be exactly 40 weeks, put a range. That's your plus minus 2. So here it is, it's 40 weeks or 280 days. So 10 moon months, 10 times 28, 280. And then you have to add, remove 2. So the answer in obstetrics exam is 40 weeks plus minus 2. That's your physiological pregnancy, okay? Yeah, so moving on to the next question. This is basically your obstetric period, okay? When talking about diseases of the baby before born, we have germinal, embryonic, fetal stage, and these are the diseases: gametopathy, embryopathy, fetopathy. That's from your genetics lesson. And then talking about more clinical, especially for pediatrics, we have to define the preterm ones, okay? So preterm. When we become pediatrician, we are going to ask the history of the baby and if he's born preterm, okay? So what is preterm and what are its classifications? How can you subdivide preterm?
Between 37 to 39 weeks.
Okay, so Victoria was more closer. She said 32 to 39, I think, or 36 to 39. Okay, so we said that it's about 40, okay? Yes, we agreed that pregnancy is about 40. But then we have to add a bit and remove a bit to have a bit range above and a bit range below. So Victoria, remember that to be term, it can be a bit above 40 and a bit below 40, okay? We have to know exactly how much is each subdivision. You need to know the limits, okay? And this is how it is, okay? Completed 37-week is when you start to be called a term, okay? So 37-week, when you see a color here, it means it's completed. So completed 37, completed 38, completed 42, that's your post-term, okay? Anything before it, we have all of these sub-classifications. And let's go through them together. So 42 and above, that's your post-term. Our term starts from 37 completed week until 41 plus 6, okay? So not completed 41. That's our term. A bit above 40, a bit below 40, okay? Our preterm is this one, mild, moderate, severe, and extreme. Okay, so it's easy to classify the disease, let's say, mild, moderate, severe, and extreme. So what happened now is that it used to be like this. We used to have mild preterm from 34 until from 34 until 36. And what happened is that the mother and the father, the parents, they were Googling mild preterm, and they were looking at all these possible diseases that the baby can have, and they were becoming stressed. So we came up with a new term. It's called late preterm. So you see that late doesn't match any mild, moderate, severe, extreme. So we have mild, moderate, severe, extreme, which is like common terms for diseases, but we have a special term called late preterm, okay? This late preterm starts from 34 weeks, okay? So 34 completed weeks is when the baby should be able to suck and eat food, okay? So 34 weeks, it means that the baby has higher survival rates because they don't want intravenous feeding. They can eat by themselves a bit. They have higher chances to survive on their own. So we call it late preterm. So this time when the parents Google late preterm, they see that there is higher chance that the baby is fine, so they don't get stressed. And we keep our preterm scary terms, mild, moderate, severe, extreme, for below 34 completed. Okay, so from 34 until 32 is mild, moderate, severe, and extreme. So yeah, use late preterm for this range. Don't use mild anymore. We don't use mild here anymore. Okay, so cancel this one. Yeah, so important for late preterm, since the baby can survive on its own. If the mother has some severe disease and we have to deliver the baby, it's safe for us to do so. So if it's very severe and it's during this time, late preterm, we say, you know what, let's just deliver. We don't care, like we're not afraid of the baby anymore. Let's deliver it because the baby has higher chances of surviving. If the mother has some severe disease and it's between 32 to 34, we might consider, you know what, let's just delay the delivery. Let's wait 1-2 weeks. Let's get, for example, high blood pressure under control with some medication. Let's try to give some symptomatic treatment until it becomes late preterm. So if we are able to make it to term, that's good. If there is some problem in late preterm, we again see the benefits to risk ratio, and we say, you know what, maybe we should deliver or not. But the negatives of late preterm delivery is not so big. So we would be more likely to deliver the baby, okay? But if it's mild, the risk is a bit higher. So we might try to postpone the delivery, okay? Then we have the gray zone of viability. Do you know what does it mean? Like why each country has different gray zone? It depends on the country.
Insurance?
Insurance, okay. So the insurance should probably cover everything. So that's not the answer. The answer basically is quality of care, access to technology, your hospitals. When we try to save the patient, we try to avoid morbidity and mortality. So there is no point in saving the child if it's going to become permanently destroyed brain, permanently diseased, you know, so he can have a worse quality of life. We try to have good quality of life. So if we know that when we try to resuscitate the baby at a point, at a gestational age, very small, and this will lead to permanent disease, we try to avoid it. Because there's no point in saving the child and then it suffers for his entire life. every country has different access to technology. For example, America, they are very good. Okay, they have so much good technology. They have very good doctors, and they say, you know what, we can try from 22 or something. Like some hospitals, they're very confident that when they deliver the baby at 22, 23, the baby will be fine because they have access to healthcare. Some poor countries, they say, you know what, even if we deliver it 24, our technology and doctors are not so good. We don't have the right medication, so the baby will suffer. So this gray zone depends on your hospital, on your confidence, and that when you try to save the baby, you should not make a permanent disability, okay? So it's based on the ability of yourself, your hospital, your team to treat the baby and make it come out with good outcome. Okay, so that's why it's different in each country. Depends on the ICU. So neonatal ICU is called NICU, okay? So neonatal ICU. So that's why it's called gray zone of viability, because different countries have different access to resources. Okay, and then we go to measuring the gestational age. Okay, what does it mean completed 37th week? When I asked you before, how do we measure the gestational age? What?
Moon cycles.
Moon cycles, okay. Last day of the period. So a woman comes to you pregnant and tells you, what are you going to ask her? You're going to ask her, when was your period? Last period. So she was bleeding for 4 days, 5 days. So you start from the 5th day or from the 1st day? When do you start calculating?
From the first day of period.
The 1st day of period. Okay, that's good.
But
So
also,
the
I know
answer-
that it can be measured by sizes in ultrasound, no?
Yes. So let's go first by step. That was correct. That was correct online. I don't know who said it, but yeah, that's correct. So basically, in obstetrics, we count day 1 of pregnancy, the first day of bleeding. Okay, so it doesn't matter how many days you bleed because it varies. We count the first one. So in obstetrics, what we try to do, we try to standardize it. So we are talking about on the same terms with different doctors, okay, to try to make it as standardized as possible. So we know that women, they bleed for many days. Like someone might bleed 1 day, another woman may bleed for 6 days. So what's the most standard way? Let's say first day of bleeding, okay? This will make everything a bit more standardized. And then what we do, the first week of pregnancy is actually number 0, okay? So when you write it, you have to write completed weeks plus days, completed days. So for example, on your first week, number 6, when you finish it, you were going to be 0 plus 6, 0 weeks plus 6. So your first week is number 0 on paper, okay? This is called LMP, last menstrual period, your first day of bleeding, okay? Now I gave you here an example. I show you a woman who is 0 plus 6. Is it possible to be 0 plus 6 and pregnant? Is this scenario possible in real life?
No.
No,
Like-
why not?
It will be hard to detect it in that time.
So we have a student here who was right. Basically, ovulation happens around 14th day. So what we are doing in obstetrics is that we are making the babies a bit older. We're giving them days, right? So if it's a standard woman having ovulation at 14, so 0 plus 14 will be when the fertilization happens. So the baby, we are calling it 14 days older, okay? But it's better to have standardized because we don't know when ovulation happened. Some of them have it on day 12, other women have it on day 18. It's variable. So again, try to make everything standardized. We choose the first day of bleeding, and we don't care that actually we're making them 14 days older, okay? So standardization is more important than details on obstetrics. So yeah, that's when we start calculating. Don't confuse yourself, even though fertilization happens around day 14, 16, whatever, we start calculating first day of bleeding. That's the easiest way to standardize it, okay? Even though we try to standardize it as much as possible, using last menstrual period can be an inaccurate method okay, for the reasons we mentioned, okay, we don't care, but why is it inaccurate? Why using the first day of bleeding could be inaccurate, like for a lot of maybe 1 month off? We're not sure. We mean the woman is not sure if she had the period or not.
On which day?
On which day? Okay, forgetting the day. Okay, what else? Amenorrhea. Okay, so we have non-standardized cycles. Do you remember in histology, you did the blastocysts and implantation? What could happen there? Remember bleeding? It could bleed during implantation. So from your embryology, you should know in histology that there is sometimes bleeding during implantation of the embryo, okay? So the woman can see this on day 16 or 18 or whatever, and she may confuse it with period, okay? So that's another inaccurate method. Yeah, so we don't know if it's period or if it's pregnancy. We don't know what does it mean, the blood. Maybe there's some tumor or something else. Just seeing blood does not mean that it was your last period. Maybe it was something else, okay? And as they mentioned online, the best method for gestational age estimation is which one? We already said it. Ultrasound, crown to ramp ratio, that's your fetus. And there's only one definitive way to know exactly the gestational age to the second, like which second, hour, minute, day the fertilization happened. There's only one way to know exactly which, what? Exactly. So you're correct. So the answer was IVF. So when you implant it by yourself, when you use IVF, when you do it yourself, that's the only definitive method to know exactly which second the fertilization happened. Okay. And this is important for when you deliver the baby. When you do IVF, it's the only, let's say, indication where you can plan your C-section at 39 plus 1. Okay. So when you do IVF, it's important because you know exactly the gestational age and you can plan the C-section at a younger age. While if it's naturally fertilized, you have to wait just to be sure, okay? We said the best method is crown to ramp length. On the first trimester, do you know why first trimester? Do you know why the first trimester is the most accurate? Okay, so this is the graph from my lecture. This is what the professor drew and how he explained it. This is week number 40, okay, that's birth. And this is the growth rate, this axis. So he starts growing very fast. This is your first trimester, and then it starts to grow, slow down the growth, and then it plateaus. Then it's get born, and then it starts to grow again. Okay, so the reason why first trimester is very important is that we have a table, and it can convert crown to ramp length, can be converted to gestational age. So this is the easiest accurate way to do it. While here, the baby will be almost the same crown to ramp length. So we don't know which gestational age it is. We cannot correlate it. That's why the woman should come for her screenings, okay? If you know some woman around that is going to be pregnant, you should tell her, go to your screenings. Don't miss it. Maybe some of them will say, it's okay, I'll just go later and they will find the disease later. No, we need to go in the beginning when the baby is growing, do all the tests. Maybe we indicate an abortion at an early age because later we cannot abort unless it's medical reasons, okay? So that's your first trimester. Also, they say we need the doctor experience, but some of the professors, they say everything needs experience, like x-rays or, so they don't like when you say you need doctor's experience for ultrasound. They say that experience is for everything, right? Even taking blood, you need some experience. The algorithm of when to use last menstruation period and crown to ramp length. When do you use ultrasound? When do you use patient history? Basically, if it's within 7 days, when the ultrasound machine spits out a gestational age, which is within 7 days to what you estimated by using the history, the patient history, they will say, you know what, the woman is right. This bleeding was correctly as a pregnancy, correlated as pregnancy. So let's start using the bleeding, last menstruation bleeding, for standardization purposes, okay? To be on the standardized way. If it's within 7 days, we say, okay, let's follow the woman, okay, patient history. If it's more than 7 days, we say, you know what, the woman, maybe she lied to us, maybe there was a different reason for bleeding. If it's more than 7 days, we say, let's go with our number, okay? So why we prefer last menstruation period is that we can make some mistakes on the ultrasound. So our experience is very important. So if we make a mistake, we prefer to go with last menstruation period, which is more standardized. If we are very good doctors and we have a very nice CRL, and then it's more than 7 days, we say that maybe there was something else, some other reason for bleeding, or maybe the woman forgot or didn't notice. So let's go with our ultrasound machine because the gap is too big to be making serious decisions based on the history, which is a bit false, okay? So this is your algorithm. Within 7 days, go with the period. More than 7 days, go with your ultrasound. Okay, moving on. This is a nice exercise, okay? So after birth of a preterm baby, what is his age? So that's the date of birth versus gestational age question. For example, I have a baby which was born 33 plus 4, then 10 weeks passed post-delivery. What is his age? How old is he? So my boy was born 33 plus 4, 10 weeks passed. What is his age? What is his age? Is he 10 weeks old?
Now it's by days.
You think
From
it's
the
less?
beginning? No,
So
like
it's-
not from the beginning, like 0 day.
Okay, so you continue calculating from the basically gestational age. So what Victoria says is that we need to keep in mind that fertilization happened at the point, and even though the baby was born, we don't care about it. We keep using that number, okay? So this is where our term corrected age comes in. We need to correct it. How to correct it? We take only the weeks, forget the plus days. Okay, so now we had 33 plus 4. Forget the plus 4, just take 33. Then how many weeks to 40 weeks? That's our pregnancy, right? Our normal pregnancy, 40 weeks. So that's 7 weeks to reach 40. Yes? Everyone all right? Everyone with me? Okay. And then subtract from birth date. So 10 weeks passed, but we have to remove the 7. So he's 3 weeks old, corrected age. This is important because we use different charts for assessments, different food for them, different vaccination protocols. Okay, so keep in mind then that when you are pregnant, your brain develops in a specific way. It doesn't matter if you are still inside the uterus or if you are delivered, the brain will continue maturing on the same way. So this child, which spent more time in the womb, and this child, which was delivered earlier, they should have the same reflexes, the same brain development. And this theory that when the baby is born, the brain is like, oh my God, I have to mature, and they will start to have all the reflexes is wrong, okay? The brain does not realize that I am outside the womb. It continues growing on the same way, okay? So when we look at the charts, we have different ones. They have different vaccinations. The immune system is a bit slower. So yeah, it doesn't matter when the delivery happened. We only care of the brain development and how it goes. So we have to correct the age. Everyone okay with this one? Any questions? Okay, moving on. What are the problems of post-term babies? They're too big. Okay. What else? Okay, so basically when we say post-term babies, all the students, they say they're too big. Okay, and this is the biggest trap. So, okay, what makes the baby big? So the babies are not necessarily big. And I prepared my presentation. I was expecting a student to say that the baby is big, okay? This is what a lot of my students as well in my class said. It depends on genetics, on mother's nutrition status, okay? How the placenta umbilical system works. So for example, I have a mother who is very, very tall. And the father of the baby is very, very, very short. So the baby, from genetic aspect, cannot be big because it averages out. Yes, we make an average of genetics. So the baby will be a bit medium, okay, but the mother is big. So there is no problem to be big. The mother is bigger than the baby in this situation. The problem, for example, when you're big is the opposite. When you have a short mom and a tall dad, then the baby is too big for the mom, okay? So you can see this in dogs sometimes when you make breeding between different like breeds, and one dog is very big and the mother is very small, and then the baby will get the genetics of the father, and then the dog will be a bit bigger than the mom. Okay, so it's the same thing. The problem here is more related to placenta. Okay, what happens to all the organs in our body? Why do we age? We have fibrosis, collagen, we have necrosis, calcifications. Okay, this is called placental insufficiency. You can see here some classifications, and these classifications, they stop the supply of nutrients and blood. Okay, it's like having infarct. It's like the heart, you know, when it gets blocked, and then you have problems with supply and demand. So the most important problem for postterms is placenta and not the size, because the size depends on many things. Nutrition, for example, if the mother eats nothing, the baby cannot grow. That's limited. Okay. If there is some disease that makes intrauterine growth restriction, the baby can be small as well. Okay. So placenta, remember, your placenta is your postterm. Okay. So what is the problem of being big? Yes, the baby can be big, but the placenta may be sufficient for it. So the ratio, right? Supply and demand. Problem with big babies is called macrosomia, being a big baby, is the ratio of baby body size to pelvic size. Okay. We say here body, not the head, the body. Okay. And then the pelvis, you know this from your clinical anatomy, additus, exitus, blah, blah, blah. And let's go to our definition, macrosomia. What is the definition of macrosomia? And which disease can it cause? Which disease is problematic? No, I mean, if you have macrosomia, what's your complication?
Maybe diabetes?
Which disease can it cause, or which complication do you have during birth?
Rupture?
Okay.
Like heart, or like the child can it can't go through the tunnel of the pelvic tunnel.
Okay, Victoria
So
is
it's
correct.
stuck, and
It's correct. So which part of the body is stuck? The shoulder, yes, good. It was answered here, the shoulder. So basically the arms, okay? So the head is delivered, and then if the body is too big, you have problem of the arms. That's your brachial plexus, okay? And the disease is called shoulder dystocia, okay? The head is coming out, the shoulders are stuck, okay? The head has some specific rotations. It's also able to change size. Remember, it's not ossified yet, so the head can come out, but the problem is the body. It's a bit difficult for the body to come out, and your brachial plexus has problems. If you have shoulder dystocia, what happens to the muscles of the affected arm? Atrophy. Yes, okay, atrophy. So you need your physiotherapy, try to fix it, okay? Now, definition of macrosomia is more than 4.2 kilograms. It has nothing to do with gestational age, okay? So macrosomia can become also in terms or in post terms, okay? We don't care of gestational age. We just look at the weight of the baby. It's born 4.2 kilos and above. How can we divide the newborns based on size? How many ways do we have to classify the newborn based on size? Do you know?
overweight, underweight.
Okay, Victoria said overweight, underweight.
Like Arabic, like height, weight.
So height compared to something like a ratio, like height to weight, or
The things I would expect they would measure what the baby's born like you.
yes, your anthropometry. But then how do you subclassify them? You say that this baby is big or small. How do you know if its baby is big? How do you know? The ratio between something and something. Okay. So basically, we can think of it as going 2 or 3 ways. Okay. The first one is only caring for the weight. We only care for the weight. The second one is let's use statistics. Let's compare it with the other children. If all the children are small and this guy is big, we say, you know what, this guy is big. If all the children are big and he's the same size, we can say this child is small. So statistics, comparing the children between them. So first one, just going by weight, okay? Only caring for the specific child. Second method, comparing them in the population. So it means that the same child, if it changes population, it can be big or small because it's statistics, right? We don't care of the actual size, we just compare it to other. And the third one is pathology, like how the pathology influenced the baby. Is it symmetrical, asymmetrical, some other pathology? So just taking the weight at birth, we don't care of gestational age, we don't care of anything else, just by weight. Macrosomia, we said 4.2 kilos and above. Then we have normal birth weight. You know, your average is 3.5. That's most of your babies, but we said that we're talking about ranges here. Okay, so range. And then we have some more details down. This is what Professor Honzik likes to ask. He asks you, tell me the preterm, tell me the moderate preterm, the extreme preterm. Tell me exactly how many grams it is. Okay, so most of the professors will ask you, tell me the weight at birth, but Professor Honzik will go even to preterm babies. Okay, he thinks that it's important, and I also think it's important to know a bit what you expect from this child. Then we said statistics. Okay, statistics involves gestational age in the population. So it can be appropriate for gestational age, small for gestational age, you know, big. We use centiles, that's our statistics. Our cutoff is 2 standard deviations from the mean. It means that the same newborn size, born in different countries, can be small in one and appropriate for another. Yes? So the same weight baby, you put in a different population, he has either big or small, statistics. And then you have your pathology. This is a diagram here I made trying to summarize all of them together, okay? Moving on, I said something about centiles, percentiles, it's the same word, but in Czech Republic, professors like to say just centile. In English is percentile. And then we have standard deviations, okay? That's your hygiene and epidemiology state exam. So do you know what is standard deviation? Do you know what is a centile?
1 by 100.
Centile is what?
1 by 100.
1 by 100. Okay, yeah, it's correct. But what does it mean? If I say third centile, so number 3, third centile, what does it mean? Belongs to 3% of the population. No, that's wrong. If we divide, okay, let's go to our graph here so you can understand better. So the mean is this is a normal distribution curve. You know what does it mean, normal distribution? So when you have a variable in the population, you're going to have a few people, for example, height, a few people too tall and a few people too short, okay? So that's your few people here and few people here on the corners. But most people will be on the mean. That's your average, okay? So most people will make the mean, okay? When you put percentages moving from left to right, you have your 0% and you move, you reach your mean. That's your 50 centile, okay? 50 centile. And then you move up and you have your 100 centile, okay? So let's start when I'm on the middle, on the mean. When I'm on the mean, in the middle, okay? I'm on the 50 centile. It means that I'm not in 50% of people, as you said. It means that 50% of people below me, so shorter, and 50% of people above me, so taller. So the number centile means how many people are behind you, okay? So if we are here, for example, on number 2, I'm on the 3rd centile. It means that 3% of people are below me, so shorter than me, and 97% of people are above me, so higher than me, okay? So the centile means where am I standing on this line, okay? And remember that the middle is 50%. So the mean, 50% above you, 50% below you. Now, the distance from the mean is counted in standard deviations, okay? There is a formula for it, but then you can start getting 1 standard deviation, 2 standard deviations, 3 standard deviations. Sometimes the pathology can be 2.5, okay? This is important for giving the boundary between physiology and pathology. Okay, if we go on the 2 centile, minus 2 centile, and plus 2 centile, you're going to have 2 standard deviations distance from the mean. So that's your 2 from 0, minus 2, or plus 2. Okay, and it will either be 3rd centile if you're minus 2, and 97th centile if you're plus 2. Okay, and because in pediatrics we said that the ranges keep moving with age, instead of memorizing for each age what is the boundaries of pathology, we just say, you know what, 2 standard deviations. If it's 2 standard deviations for the mean for that age, that's a pathology. Okay, sometimes we use 95th centile or 2.5 standard deviations to start the pathology, but most of them will be 2 standard deviations. Okay. Is it possible for someone to be below the 3rd centile and still be physiology, still be normal? Or is everyone below 3rd centile a pathology? Always. The population does not affect my curve. So the population will affect the actual number, but the centile is a relative number. Okay, so 3rd centile means in the population, you are on the 3rd% who are below you physiology. Okay, so 3% are below you, let's say, shorter, and they are physiologically shorter. We don't care of the exact number. We don't care if it's 1 meter or 2 meters height. These centiles are relative. That's why you can use it in the entire world of pediatrics. We just say 2 standard deviations and it's correct. Okay, the absolute amount might change, but the relative one, which is centiles, will not change. So what does it mean 3rd centile? We said that below us exists 3% of the population, and that's physiology. Okay, so the chances of being physiology below 3rd centile is 3%, but we know that pathology has a very high chance to have this number. Okay, for example, someone enters through the door, okay, and he's super tall. As a doctor, I look at him and I say, oh my God, he's too tall. He's over the 97th centile for his height, for his age. So I start to panic. I'm like, oh my God, acromegaly, some disease, you know, growth hormone tumors. And then he turns to me and he says, I'm actually the tallest man in the world, physiologically. So he exists. He's the tallest man in the world. But the chances of him being the physiology tallest man in the world is too small compared to the number of acromegaly people that will pass through my door, okay? So in statistics, we know that below the 3rd centile and above the 97th centile, there will be 3% who are physiologically and 3% who are physiologically on either side. But the chances that there is pathology is higher. So we assume them as pathology until proven otherwise. Okay, understand the statistics? Okay, now I'll give you an example. This is the weight chart. Okay, so we have here, always remember, when you plot, it's good to memorize these numbers here. It's good to memorize them. I memorize them, okay, it's easy. We have 3, 10, 25, 50, 75, 90, and 97. Okay, that's your centiles. Most people will follow the orange line, the 50 centile, because as we know from the graph, most people will be on the mean. And my question to you now, to see if you understood the concept of statistics, how many people will be physiological below this line, in this area, below the pink line? 3%. How many people will be physiologically above the pink line in this area? 3%. How many people will be between the green and the pink here physiologically, this area? This area over here, between the green and the pink. How many people will be physiologically found there? So that's 7. You're on the 10th centile, but this line is the 3rd centile. So 7% will be in this area, and then 3% will be in this area. Yes, what we said before. Understand? So this is how the centiles work. Okay? If you see someone below the 3rd or above the 97, assume pathology, start investigation until proven otherwise healthy, because the chances that they are normal is too low. Okay, got this? Okay, good. So that's your sentence. Now let's go to the post-term, back to the post-term problems. What is induction? Do you know what is induction? Induction of labor? Yes, and this is the iatrogenic one, okay? So we give them some medication, some mechanical stimulus, and then they start to have the contractions, okay? So when you see a post-term baby, you say, you know what, contractions didn't start yet, let's make them iatrogenically, okay? So when do we do the iatrogenic induction of labor? So wait, 36 weeks. We said that the normal pregnancy is about 40, and the post-term is 42.
I think we cannot hear you.
You can hear me or not? Can you hear me? Hello? Can you hear me? I can hear you. Okay, so we can hear. Okay. Okay, so when we do some induction, the reason is to prevent the placental insufficiency, right? So we said that the post-terms have it. So let's not allow them to go post-term. So post-term is 42 weeks completed. Yes. So when you, Sriram, right? So when would you do the induction again? One more time?
42.
42. Okay. So what the actual term that the obstetrics use is 7 to 10 days after the beginning of 41 week. So that's basically 42 plus 3 or something. Okay. But I wrote exactly what he said in the lecture, and I was gonna say this one, like 7 to 10 days after 41, because maybe he meant within 7 to 10 days. Maybe he meant within. I don't know what he meant, but this is what I wrote. That was what I was going to say in the exam. When you have your obstetrics, ask them, okay, to verify it. Why not wait longer, and why not do it earlier? As you said, 36 weeks. Why not do it earlier? Why not wait longer than 42 weeks? Okay, longer, we said because of placenta insufficiency, and earlier because of development, because of the inaccuracy in estimating gestational age. The only way we can do it earlier, as we said, no, okay, yeah, IVF, okay. Remember, your IVF is the only one you know exactly what is going on. So you say, you know what, 39 plus 1, let's do a C-section, take the baby out, okay? That's the only way you can do it based on your theory, okay? But in nature and natural fertilization, we might have the wrong gestational age. Our estimation is not so good. So for example, if the baby is 38 weeks gestational age instead of 41, as we predicted, the baby is mature, so I can take it out on 41 and not make any problem to it, okay? But if I take it out on 39 or 40, maybe the baby is 36 and I make problem to it, okay? So it's better to be on the safer side, like let it grow a bit and try to have it as term than actually taking it out earlier and actually the placental insufficiency is not there, okay? So we prefer to go on the bigger side of things. And we said 7 to 10 days after 41 week. Okay, do the induction. Now let's go to our pediatrics. Okay, so how do we divide the pediatric patients according to age? So we said obstetrics is our preterms, postterms, blah, blah, blah. And our pediatrics after birth, we have a bit louder. What does it mean prenatal? So it's not no prenatal because pediatrician takes the baby from birth. So neonatal. Okay. Yes, so this is the periods you need to know for your exam. And each period has different theory and different diseases, okay? And today we will talk about puberty, which is one of these periods, okay? So that's how it goes. Neonate, you found this, okay? Neonate is split into early and late. Okay, so 28 days. I like to think in my brain about 1 month, but you have to know 28 days. So the first week is the most important because there is adaptation to extrauterine environment. This is the most critical period. Okay, the baby is learning to adapt to the temperature, to the breathing, you know, all these adaptations. If something goes wrong, we get diseases, especially in preterms. Okay, so that's our early neonate, high risk period. And then you have the late neonate, that's your neonatologist. Okay, is a pediatrician and specialty is neonatology. That's your 28 days. Okay, then we have infant, that's until your first year. Okay, and then we have toddler, 1 to 3 years. I wrote here it lasts 2 years, so toddler is 2 years. How do we calculate when is a toddler? When I say 1 to 3 years, when does it start the toddler? When does it finish? So the answer is based on the candle you blow. Okay, so when you blow the candle on your cake number 1, and when you blow the candle number 3, you are a toddler. How many years passed? I blow the candle number 1, 1 year passes. I blow candle number 2, 1 year passes. I blow candle number 3. So that's 2 years, right? So when you say 1 to 3, we are talking candle to candle. Okay, 2 years. So preschool, how many years is preschool? 3 to 6, so how many years? 3 years, okay? From candle 3 to candle 6, that's your preschool, okay? That's how you remember it. Then you have school and then adolescence, okay? Adolescence is split into early, middle, and late because important in adolescence is how your brain develops, how your maturity develops to become an adult, okay? The way of thinking, your morals and all these things, okay? Please note that animals don't have childhood slowdown, okay? They don't have puberty. They keep growing. From the day they're born, they grow and grow and grow and grow and grow, okay? While humans, they grow a bit, then they stop to grow, then they have puberty and they grow again, okay? So we have like kind of like a bimodal thing, humans, while all the animals, they just keep growing, okay? So our lecture is puberty, but there is no puberty period. What is going on? Why there is no puberty period in the pediatrics? Everyone knows in school that, yeah, teenagers, puberty, but actually in medicine, we don't have puberty. We have adolescence. Why?
Because it's by a process, it's not by a year, that you cannot say that everyone, the puberty starts at the same time.
Okay, so Victoria is right. Okay, that's one of the things, that puberty varies between the patients. Okay, some start earlier, some lower, some start earlier and later. But the most important thing, and this is where we start our physiology of lecture, okay? So puberty physiology. The most important thing is that adolescence, as we said, is becoming an adult, okay? Adolescence is psychosocial development. We said that the brain is following a specific predetermined way of maturing, okay? So adolescence, we are talking about the brain, the way it matures. That's why we said the preterms, we cannot, we have to correct the age because the brain is programmed to develop in a specific way, okay? So following this theory that the brain should be developed in a specific way, we can use that one to define adolescence. That by age 10 to 19, the brain should be developing and becoming more mature. So that's why we use adolescence to define the periods, okay? Puberty, as Victoria said, is a hormonally regulated physical change of sexual maturation and growth, okay? It ends with the individual's ability to reproduce. So remember, this is my mnemonic. Adult way of thinking is adolescent, okay? And physical changes of sexual development and growth is your puberty. And puberty varies, okay? While adolescence should be following the brain development. Here, my example, as you can see from the dysmorphic features, what disease does this patient suffer from? Which syndrome? Okay, maybe it's not that visible. Down syndrome, yes, correct, syndrome. So this is a patient of Down syndrome. He's having problems in brain development, okay? But he's able to have a beard, to have growth, his genitals are maturing. So he hit puberty, puberty is fine, his sexual maturation is fine, he can reproduce, but his brain is lacking a bit behind. So he didn't hit adolescence yet. He has problem with adolescence, okay? So remember that adolescence is your brain and puberty is physical changes, okay? Definitions now. What are primary and secondary sexual characteristics? This here should be males and females sign. What is the ability to reproduce in males and females? Now, the first two questions, the yellow ones. Sexual characteristics. Have you heard this before? Primary, secondary? What are they?
You have the hormone levels, I think, but secondary is where that you start developing the characteristics, like for example, for males, like broad chest, for instance.
You're right, but the proper definition for primary, tell me again the proper definition for primary sexual characteristics.
Biologically be apparent.
Okay. Yes, this is better definition. So primary sexual characteristics, you have it from the day you are born, but it's not necessarily mature, okay? So gonads, fallopian tubes, uterus, they are there since birth. You need them for reproduction, but they are not mature. They have wrong epithelium, wrong size, wrong cells inside, okay? We need to make them mature. That's your primary. Everything needed for reproduction. Secondary, they are gender specific and is what is going to be the result of your hormonal, like testosterone, estrogens, and things like this, gender specific, like beard, as you said, muscles, broad chest, that's your secondary, okay? And the ability to reproduce in males and females, that's your spermatogenesis and ovulation, okay? So that's the two things. You need your mature ovum and mature sperm. And pseudo-puberty, definition of pseudo-puberty. It's related to the first question. So pseudo-puberty, it has to do with sexual. No. Primary characteristic would like secondary. So exactly the opposite. What Sean said, but exactly the opposite. Sean, exactly the opposite. So Sean said, you saw primary characteristics we lacking secondary. That's the exactly opposite. So it's secondary characteristics with lacking the maturation of the primary. So you see a patient coming with beard, deep voice, broad chest, muscles, but his testicles are not mature. So he cannot reproduce, but he looks like he went through puberty. That's why it's called pseudo-puberty. He looks like puberty, but his gonads and everything needed, the primary needed for reproduction are not there, okay? So we said primary, relations, spermatogenesis, secondary, everything else, no gonadal maturation. For example, congenital adrenal hyperplasia, 21 alpha hydroxylase deficiency, a classic, simple virilizing version, that would be your pseudo-puberty, okay? You have your hormones making you secondary, but not maturing the primary. To mature the primary, you need to have a proper stimulation from the GnRH, LH-FSH down to the gonads axis. If it doesn't go orthodromic, they will not mature. So if I inject you with testosterone, estrogens, you will have your secondary characteristics, but not your gonads maturation. FSH, LH, pulsatile stimulation, proper is needed for gonadal maturation. Otherwise, they don't mature, okay? Moving on. The three, and now going to endocrine, okay? This is the endocrine part of puberty. So 3 hormonal axes involved in puberty. Okay, which one do you think? Yes, so which hormone specifically? Because all 3 of them go this way, I think. So I mentioned one, which is, so GnRH axis. That's the same axis. So GnRH. That's not puberty. That's the same axis. So you're saying one axis. Okay, if you look here, what does it mean, arche in Greek? Start, okay? Arche means start. And we're going to have here adrenarche and gonadarche. So gonadarche you said already. So what is adrenarche? Which axis? So which axis? ACTH. Yeah, okay. So the answer is adrenarche. That's your ACTH to the adrenals. Gonadarche, GnRH to the gonads, and also growth hormone. Okay. You mentioned thyroid and insulin. That's pre-puberty for growth. Okay. And then in puberty, growth turns to growth hormone. So adrenarche, gonadarche would be our physical changes in puberty, and growth hormone is also a physical change. And we said puberty is physical changes. So we need to grow, we need to have pubic hair, we need to have maturation of the gonads, maturation of secondary characteristics. So these three axes are very important in achieving physical changes of your body in puberty, which is basically the definition of puberty, right? Physical changes and sexual maturation. Okay, adrenarche, let's go with the first one. Adrenals already have function since gestation. How many weeks? How many weeks gestation? That's your embryology and pediatrics. Histology, embryology. 32 weeks. Do you know when it happens, the reproductive tract? Okay, so my next presentation after puberty is sex development. So you can watch that one, and I have all the embryology summarized really fast. So we can go through that. Okay, basically it's about 7 to 9 weeks. Okay, 7 to 9 weeks. Are the adrenals functioning during the embryogenesis of reproductive system? Yes, they have to. We need to have a bit of adrenal function to help with the embryogenesis, okay? 7 to 9 weeks. So we talked about adrenarche, so the beginning of adrenals. So when do you think adrenarche definition comes in? We're talking about puberty, but they're already functioning since gestation. So adrenarche is when? During gestation or during puberty? What do you think? Okay, not during gestation. It's during puberty, okay? Adrenarche is one of our pillars, we said, and why we choose puberty to define the beginning of adrenals is because what changes in puberty is the pulsatile fashion, the pattern, okay? So endocrinology, remember, it's not just the value of the hormone, like the basal or whatever. Some hormones have like diurnal or pulsatile release, yes, like cortisol. Remember that it's not just the value, it's also the pattern of it, okay? Do you know some hormones that have a pattern? Yes, what else? Okay, so GnRH axis, what other axis? Yes, but it's based on food, okay? So we're talking about adrenarche, melatonin, okay, good. Melatonin also depends on the light, yes. Adrenals, ACTH, cortisol, yeah, good. And Sean is trying to write something else. What was the third axis we talked about? Growth hormone. So growth hormone also is pulsatile. Okay. Why am I telling you about the pulsatile fashion? Because as an endocrinologist, when your patient comes in, you want to do some blood tests. Okay. And you want this blood test to be helpful. You get some information about it. So imagine that the same patient, he has value of 10 for ACTH in the morning and a value of 3 during the afternoon. And I take his blood in midday and I see number 6. What does it tell me? It tells me nothing. If the same patient has in the morning like 100 and again 7 in the afternoon, and I take it towards the afternoon and I see 6 again, it tells me nothing, okay? So in endocrinology, some hormones which are changing during the day, what I need to do is called a dynamic test. Have you heard of dynamic testing before? Okay, so dynamic testing is when I stress the axis. I go in the beginning of the axis and I either stimulate it or inhibit it, and I see how the axis reacts. This can be interpreted. This can tell me something, okay? So dynamic testing can be interpreted in some cases where the basal number is not interpretable, okay? So we said for pre-adrenals, the ACTH stimulates cortisol, that's your survival, okay? But not your sex maturation, your dihydroepiandrosterone. We said about dynamic testing, yes, pulsatile, examples, ACTH, growth hormone, GnRH. These three things is our axis for puberty. We need dynamic testing, okay? Either stimulation or inhibition. FSH-LH, you can actually take the basal. Testosterone, you can actually take the basal. But GnRH, you need to make dynamic testing, okay, to see the axis. So you stimulate the axis from the top and see how it reacts, okay? These, you know, primary, secondary from pathology, peripheral, central, these classifications. So you stimulate the beginning and you can differentiate between central, hypothalamus, and pituitary. Yes? So dynamic testing, that's an important thing for endocrine. So what happens during puberty? So we said cortisol remains the same. It was already active before, during gestation. It's diurnal, highest before waking up. What changes is the sulfation of dihydroepiandrosterone. Remember that dihydroepiandrosterone is the mother of testosterone and estrogens, yes, down the tree. However, at this point, because it happens first between 5, I don't know if I show it to you. It happens first, no, it's blocked. It happens first at 5 to 8. It happens first at 5 to 8 years old, okay? So your adrenals happens first. They are separate from the gonadal axis, so they don't damage to one axis, does not affect the other axis. It happens 1 to 2 years before gonadal, okay? But it will not lead to gonadal maturation, okay? It will have different effects. So it happens first. To measure if it's happening or not, we need to measure the sulfated dihydroepiandrosterone level. So DHEAS level is the most important marker for adrenarche. Yeah, and this will cause puberty. Do you know what is puberty? No, not puba. Pubis. Exactly. So that's pubic hair. That's the second image. First pubic hair, then axillary hair as well. And it's when adrenals is only in males or females or both. Adrenals. Where do you find them? Males, females, or both? Adrenal glands are both, right? So adrenal hair happens in both. So when we talk about features of adrenal hair, remember it happens in both, right? So both of them have adrenals. So not the beard. Don't say beard hair, okay? We say pubic hair, axillary hair. Beard is a secondary sexual characteristic of men, okay? So pubic hair, axillary hair, and also it affects skin odor due to sebaceous and apocrine sweat glands, and this causes acne. This is very important for Professor Zeman, okay? He likes when you go to puberty, you have to say adrenals, they are going to affect the glands, and then we get acne, okay? So remember three images, that's your adrenals, both in males and females, okay? How do you measure them? Sulfated, okay? Dihydroepiandrosterone sulfated. And here I have the biochem. Remember cholesterol, this is your adrenals. DHEA is going to become your testosterone and estrogens, but at this point is becoming sulfated. In the beginning of adrenal hair, becoming sulfated. What is happening is your zona radicularis is maturing, okay? That's it, that's the first axis. Any questions for the first axis? We also have some other things affecting the axis, okay. Any questions on adrenal hair? Adrenarche is defined as pulsatile, like pattern. Before there is no pattern. It's just ACTH making cortisol. 5 to 8 years old. Yes, 5 to 8 years old. Not maturation. It's going to have a delayed effect of pubic hair, axillary hair, glands, which means acne and body odor. The glands and acne development. So the glands are basically changing their morphology, maturing, and they change their chemicals. So that's why you get your odor, your adult odor. Okay, that's why men, they smell while the boys, they don't smell. This is part of the courting, you know, like you smell the pheromones, blah, blah, blah. So that's needed for reproduction. It's one part of reproduction. So when the glands start to secrete and all these things and the keratinocytes multiply, then they can block the hair, and then you can have your acne. You know, whiteheads, blackheads, oxidation. Blackheads are oxidized. That's your open comatose. Then white, that's your closed comatose. Yes? That's your acne with adrenals. So not testosterone, not estrogen for acne. It's adrenals. Okay? Body odor, acne, pubic hair, and axillary hair. Not beard. Some students, they say beard because they say, okay, hair, let's say all the hair. No, don't say all the hair. The women don't have beard. Okay? Whatever is common in both, that's your adrenals. Dislocation. Okay, moving now. Yes, thank you. Good. Okay, moving now to gonadarche. That's which axis, which hormones? Axis of, for gonads? GnRH, then FSHLH, then either testes or ovaries. That's your gonads, okay? And then they will either create testosterone or the estrogens, okay? What is gonadostat? Gonadostat, this term, gonadostat. What? Okay, do you know what is a thermostat? Yeah, how does it move? On, off, on, off. It's like a pulsatile. So gonadostat is what doctors use to describe the pattern and pulsatile release of these hormones, okay? When you talk about gonadostat, always use, the easiest way to do it is always use negative feedback to testosterone and estrogen, okay? You remember from physiology, the axis. Testosterone and estradiol, they're going to make a negative feedback to the gonadostat, okay? So when you go to explain your gonadostat during the different age periods, just use negative feedback. That's the easiest way to do it, okay? Just memorize how the negative feedback works and everything else is logic. Okay, so how many age periods are we going to talk about? Until puberty. So fetus, infant, school age, and then puberty, okay? So that's my four age periods. You know this from physiology. We're talking about pulse, yes. How am I going to test GnRH? Which test? Am I taking basal or dynamic? Dynamic, good. Okay, so there is some diseases of GnRH, and they have to do with migration of some cells, which are responsible for GnRH production. Do you know where do GnRH hypothalamic neuronal cells come from? This green question here. Yeah, so DTI is correct. And do you know what is the name of the disease? So if you Kalman, okay, good. So yeah, Aditya is correct. Someone is studying for internal. Okay, so they come from the nose, olfactory placode, okay? And he said Kalman syndrome, that's one of the diseases, the most hot one, which is manifested as anosmia and also hypogonadism, hypogonadotropin hypogonadism, okay? But there's also another disease, which is chromosomally based. It's taught as a chromosomal disease, but actually the pathophysiology, if you look at the pathophysiology, there's also some problem in this migration, and it actually stimulates hypothalamus in a different way. So which disease is hyperphagia and hypogonadotropin, hypogonadism. Hyperphagia with central hypogonadism. Hyperphagia? Ashnia, no. Aditya, no. Okay, I'll give you the answer. It's Prader-Willi. So Prader-Willi, they have the hypogonadism, okay, because of the GnRH problem. Hyperphagia means they eat a lot. They eat. They're always hungry, okay? And this is not because of the body telling you you don't have energy. It's because the brain is stimulated due to this pathophysis problem. It's stimulated, okay? And they make you hungry all the time. So if you see Prader-Willi patients, they are overweight, okay? And they're always hungry. So remember these two diseases. And olfactory plagote. This is from your internal. If you started studying internal. Okay, fetal period. As we said, gonadostat, always go negative feedback. That's the easiest way. So what happens in fetal period? Is the negative feedback high or low? So it starts from one extreme and then goes to the other extreme, okay? Does it start with a lot of negative feedback that the GnRH does not work? Or does it start with no negative feedback, GnRH is super high? Which of the extremes do you think? Super high GnRH or super low GnRH during fetal period? It's 50-50%. Try. Always high? Yes, you're correct. So negative feedback has no effect on GnRH. Okay? Why is this needed? To make the baby male or female. Okay? It's going to change the gonads. Okay? We have Leydig cells, primordial germ cells, and yeah, this is basically how it matures. The testis, yes, on the male. And in female, we have the same thing, primordial germ cells, primordial ovum, and it's going to stop at prophase 1 until puberty, okay? So that's why in fetal period, we need a lot of GnRH. We need to stimulate them, change them from the embryonal into either ovaries or testes, okay? Not completely mature. This here happens after puberty, okay? I put them there just for you to have it as reference when you read the slide. So we need the GnRH during fetal period. It's important. Then infant period. Child is born, okay? What happens in infant period in terms of negative feedback? We said that we started with no negative feedback. GnRH doesn't care. It's stimulated. Now infant is increasing, okay? So it's increasing. Sensitivity to negative feedback is increasing. So the infant will have lower levels. But still, there is something called mini puberty. Do you know what is mini puberty? This is a pediatrics. You only find it in pediatrics. Mini puberty. What is it? A new term from pediatrics?
Then it gets negative again.
Exactly. So from the day you're born, you start to have the hormones going up and down. Okay. So it's similar to the puberty, but there is less maturation. Not completely maturation, but less maturation. So if we look at it, at birth until in the lecture, they said 4 to 6 months. This diagram just have like 6 months. So from birth until 4 to 6 months, this over here is your mini puberty, this spike. Okay, you can see here in infancy, there's a spike. Mini puberty. After delivery until 4 to 6 months, pulsatile, remember, not just the value, but also the pattern is important in endocrinology. We have some testicular descent. Remember that for preterms, you have to wait until 34 weeks to descend. Otherwise, you diagnose it as cryptorchidism. Good. In girls, there's some increased breast size. Yeah, if you have some pathology, then you have problem with the estrogen levels. So that's your mini puberty, penile growth, testicular volume increases, descent. So it's kind of a bit like puberty, but not maturing you and making you an adult reproductive person. It's just the first step, okay? First step between males and females. That's your mini puberty. So from birth until 4 to 6 months. Then childhood. What happens in the childhood in terms of negative feedback? It's still getting higher. Good. That's the highest, actually. In childhood, we have so much negative feedback that GnRH is minimum. Okay, so childhood is a human-specific species period. We said all the other animals, they just keep growing from birth until adulthood. They grow, 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 grow. Humans, we have a slowdown, childhood period. Okay, that's our highest negative feedback. Humans have this, all the animals don't have this. And then we have a puberty. What happens in the negative feedback? Puberty. So it goes down again. Good, Sriram. It goes down. No feedback. High GnRH. Yeah. So that's correct. That's your highest. It goes up, 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 up. Okay. So lowest feedback, highest pulse, goes up, up, up. And then in the adult, you have your cycles, right? These cycles is woman, and the line below is man. Okay. We know that the man doesn't have cycles. It's always creating sperm. The woman has cycles in ovulation. Okay, for endocrinology enthusiasts, know that FSH is less connected to the pulse. It's a long-term marker, similar to diabetes when you have hemoglobin A1C, yeah, glycated hemoglobin, which is not basically your glycemia at the moment, but it's more long-term. So that's when we want to see GnRH. If you look at FSH, it will tell you long-term. If you look at LH, it's going to actually follow the pulse, okay? So when you make tests, you want to know right now what is going on, look at LH. If you want to know the general situation on the long term, look at FSH. That's the difference between the two. Gonadarchy is basically sensitivity of gonads to LH, FSH increases, more sex hormones are produced, and you have the symptoms of gonadarchy, okay? Gonadarchy is actually your onset of puberty. When we speak about onset of puberty, we know that the adrenals happen at 5 to 8 years old, but now we care about gonadarchy. When we start to see the puberty, it's actually gonadarchy. Okay, so the gonads are responsible for what you see, the first symptom. Remember, pulsatile. So if it's continuous GnRH and not pulsatile secretion, LH, FSH become desensitized and are suppressed. Okay, so this is the basis for some contraception pills. Again, remember, not just the value, also the pattern is important in endocrine. We stimulate GnRH. If you are in physiology second year and you don't understand the concept, you will be like, okay, GnRH is stimulated, more FSH, more LH. No, LH, FSH, they want pattern as well. Okay, so if I inject a lot of GnRH, LH, FSH will stop. Okay, so that's like the magic of endocrinology, that the pattern affects downstream values. Yeah. What determines gonadarchy? So this is the determinants of when the puberty happens. We have neurohormones, right? Neurotransmitters, hormones, limbic system. So that's your psychology and emotions. If someone is raped or neglected or traumatized, they will have different variations in onset of puberty. For endocrinology enthusiasts who want to become endocrine, kisspeptin, KIS1 gene and its receptor, kisspeptin, it was found to actually be the hormone that is above GnRH. So we learned classically GnRH, LH, FSH, testosterone, and estrogens. We found that kisspeptin, KIS1, is one step above GnRH. So when we find that there is a problem in GnRH, we can actually treat it by using kisspeptin. Okay, so it's like a fourth step in the axis, but that's still under research. Okay, we're still doing research for that. Yeah, so that's your brain, emotions, your psychology. Okay, then you have genetics, family history. So when you go to see problems of puberty, ask the parents, when did you have your puberty? When did the brother of the child have the puberty? When did the sister have it? When did the father have it? You know, genetics, any diseases in the family. And then nutrition. We know that obesity, they have earlier puberty. Okay, so if you say this like determinants or risk factors about the gonadarchy, then you're good to go. What is the one thing needed for external genitalia maturation? 1, 2 things needed to make external male genitalia maturation, let's say. Androgens. So testosterone and dihydrotestosterone. Okay, 2 things. Your androgens are the ones that will determine if you will have female genitals or male genitals. If a woman has a lot of testosterone and dihydrotestosterone, she will have male genitals. If a man doesn't have this, he will have female genitals, okay? So for external, what do you see? When you see this thing, it's your physical exam. Remember that you are only looking at testosterone and dihydrotestosterone, only androgens. You have no idea what the hell is going on with estrogens, okay? What do you see in the genitals, physical exam? Remember, it is androgens, okay? That's important for congenital adrenal hyperplasia. What are the effects of gonadotrophy and what age it happens in Czech Republic, females and males? So remember, every country has different. So we have an exam in Czech Republic, so we need to know Czech Republic. When does gonadotrophy, which is actually the onset of puberty, happens in males and females in Czech Republic? What age? Okay, is it first in females or first in males? First in females. How much faster? 6 months, 1 year, 1.5 years? Aditya says 2 years. What do you say? Okay, keep it simple. 1 year. Okay, 1 year. What is the how long is the difference between peak growth rate in females and peak growth rate in males? How long after the males get the peak growth? 1 year. Okay, just remember 1 year. From your peak growth rates until your first menstrual bleeding, how long does it take? 1 year. From your peak growth rate as a man to your first ejaculation, how long it takes? 1 year. Good. 1 year for everything. That's easy. Okay. 1 year difference in women, 1 year difference in peak growth rate. 1 year after peak growth rate is your menarche or your ejaculation. Ejaculation happens first at night or first during the day in males? First at night. Good. Okay. That's it. So the age, can you guess the age? So you said a number, but like physiology, range, always a range, because we need the standard deviations. 2 standard deviations above is delayed, below it's early puberty. So range. Wait, female or male? Female is 9 to 13. Okay, male. So 1 year later. Good. I like the way you think. You are right, it's 1 year, but you are wrong, Sriram. You based your answer on the wrong one. Okay, so basically females 8 to 13. What did you say?
9 to 13.
Yeah, okay. So 8 to 13 and 9 to 14, and that's the average in between. Yeah, so 1 year difference, okay? What are the effects of gonadotrophy? We said FSH LH, you can read this at home. It's basically gonads. I told you to have mature gonads, you need orthodromic stimulation from GnRH to LH-FSH, and then to the androgens. And yeah, why do I have this? Is it going to stop? Hope it doesn't stop. Okay, then testosterone, that's your secondary sexual characteristics, right? So FSH-LH, primary characteristics, testosterone, also the secondary. Okay, so a bit of primary, also secondary. So we have for male, remember, testosterone and dihydrotestosterone is needed for external genital maturation. We're gonna go in detail when we do the sex development lecture, okay, later on in another day. Then we have all the organs becoming bigger, descent of testes, hair, male baldness, all these things, larynx, lower voice, yes, for men, protein synthesis, that's your muscle. And remember, muscle has more water, so higher total body water in men than females. Skin is thicker, another risk factor for acne. That's why men have a bit more acne than females. Bone matrix, this is very important, okay? Important thing in puberty is that your bone will ossify and you will have no longer growth plates, okay? Which one is going to have a bigger effect on fusing the growth plates? Estrogens or androgens? Who fuses, which gender has the fastest fusage of growth plates? Estrogens, good. So estrogens will fuse the bone faster. That's why girls are shorter. Okay. Yeah. Okay, so that's your epigenetic growth plate. You can read this information at home. Honzik like to ask which bone fuses last. That's the spine. And he likes to ask how much percent of the final height addition is created by the spine. And that's 15%. Okay, Honzik likes to ask this. Also, you have the cells, bone marrow, higher hematocrit in males. That's just testosterone. Okay, estrogen, no effect on the red blood cells, lower hematocrit. Okay, that's your testosterone. And for females, ovarian and menstrual cycles, right? Estrogen, menstrual, LH, FSH, ovarian. Yes, LH surge. So FSH, LH is your ovarian cycle. Remember, anovulatory cycles. You know what does it mean? An ovulatory cycle. No ovulation. Okay, good. There is no ovulation because the LH surge is not potent enough. Okay, so LH surge is needed for ovulation. If it's not potent enough, you will not have ovulation. This will make a shorter cycle. Okay, no progesterone is released, and you have a shorter cycle. When does an ovulation happen? Like, let's say, physiologically, when to expect it? Physiologically, before menopause and during the first 2 years of puberty. 50 to 90% of the cycles in the beginning of puberty are anovulatory. So remember, for the female, when she starts the reproductive years and when she finishes the reproductive years, there is anovulatory cycles, okay? It's like a transition. It's like a sign of, look, something's changing. You're either beginning your reproductive years or stopping your reproductive years, okay? Menarche and menopause, the transition between anovulatory cycles. And then, yeah, okay. Estrogens, we said, bone, growth plates, okay? Another thing for estrogen, 25% of body weight is fat. So that's your female fat distribution. Where does it go? The fat, in the breast, buttocks, thigh. Yeah, that's different fat distribution than men. We have the sizes of the primary and secondary characteristics. Okay, bone, we said about this. And the skin now. One thing about the skin. We have 4 types of, let's say, humans, okay? Girl, boy, man, woman. Who has the thickest skin from these 4? Men, okay? Men have the rougher skin. Then second one is woman, okay? So women have softer skin than men, but actually harder skin than boys and girls. So boys and girls, they go together. Why? Because they start to diverge during puberty. Before puberty, they have the same skin. That's why we say baby skin, right? You don't say woman's, you don't say girl skin or boy skin. So before puberty, they follow the same hormones a bit, okay? So they should be a bit similar, okay? The boys maybe a bit rougher, but the baby skin is a bit equal. Then the men will be the roughest, and female and women will be between pre-pubertal and men, okay? Just know that this happens with the skin. Yeah, it's another thing you can check on physical exam, okay? Then we have the senescence, so that's senile. Why does this is the woman, right? Why does it go so high in women? It goes pretty high, pretty fast. Why? FSH, LH. Why do they go so high? No negative feedback. Bravo, Sriram. Good. That's no negative feedback. Yeah, Aditya. Good, Aditya. Okay, so no ovary estrogen negative feedback because all the follicles are like an atrophied. Okay. Okay, good. So that's a review. High, you differentiate the gonads. Mini puberty, childhood, nothing happens. Puberty, grows. Adult, pulsatile or not. And then you have senescence. Okay. Then growth hormone. That's our last hormone for today. Which age period has the highest growth hormone axis? Which age period? Puberty, good. That's the puberty is the highest. Remember that the animals before, they don't have the childhood slowdown. So that's childhood, 5 to 7.5 centimeter per year. And then in puberty, they start to grow, okay? Females, they grow slower than males, okay? But the females, they start growing since onset of puberty, okay? So remember, like onset of puberty for females is the breast and the growth, while the beginning of puberty in males is only testicular volume, okay? So when you speak about onset of puberty in females, add the growth rate as well, okay? Remember that sex development happens faster. It ends in 2-3 years, while the growth is 4 to 5 years, okay? Okay, let's move on. Okay, this growth, remember for Honzik, he will ask you what is the problem of puberty growing too fast. So you have to say that you have high alkaline phosphatase, ALP. Okay, ALP, alkaline phosphatase, that's the enzyme for bone creation. And also that you are using up all your nutrients, so you have higher risk for fractures. Okay, so orthopedic problems could be as well. We said for growth hormone, dynamic test. Okay. Yeah, another thing about for endocrinology, know that growth hormone is diabetogenic. It creates diabetes. Okay, so that's why we avoid to use growth hormone therapy. We need to be very careful, and we use it only on indicated cases. Okay, we don't want everyone. We don't try to make everyone growth hormone. Only indicated cases. What is the difference between length and height? So in anthropometry paper, you're going to have one table for length and one table for height. What is the difference? Definition. Okay, I will help you. When do we switch from length to height? Height when you can walk, length when you're born. Okay, good. So basically, the difference is how you measure it. Length is baby on a measuring bed. Important. The head, one doctor holds the head or a nurse and put it there straight, and one hold the legs as extend as possible. Okay, every centimeter is important. That's why we need to be standardized. If the head is a bit down or the legs are a bit up, you lose a few centimeters, and that can put you into diagnosis of pathology. Okay, so every centimeter is important. When the child is standing, that's more than 2 years old. Okay, we use a stadiometer. This is what we prefer in hospitals. Like you just put the kids standing straight and the head to the wall, and you measure from the top of the head to the bottom. Okay, standing straight. Every centimeter counts. There is new machine which is laser based. You just tell him stand there. But the problem with this is that we cannot make him stand straight or put the head against the wall. Okay, because you see that the machine needs to have a bit of length. So that's why we prefer this one, the stadiometer, the classic one. Okay, that's your height and length. Onset of puberty, we set the age, we set what is the first sign, telarchy in females and growth, while it's only testicular volume in males. 1 year after peak growth is your menarche, and 1 year after peak growth is your ejaculation. Okay, and they have 1 year apart because of the puberty 1 year. Don't say menarche because a lot of students before us failed, because when they were asked what is the first sign of puberty, they just said, I don't know, bleeding, menarche. No, menarche happens very late, happens at 13 years old. And this woman already since 10 years has the telarchy and growth rate, okay? Breast and growth in women. Testicles in males, okay? Ejaculation and menarche are late events. Know this one. Okay? So yeah, in general, if they ask you what is the general trend, you just say that moving on with the years. Remember I told you that anthropometry and all the data are revised every 2-3 years. So every 2-3 years, we have to change the onset of puberty is getting younger and younger, okay? But the menarche still remains the same. Therefore, the people remain in puberty longer, okay? Determinants, what you need to take for your patient history. Remember that family history is important as well. You ask the mother, you ask the brother, sister, when they have the puberty, okay? That's your genetics. You can read this at home. Okay, this is a summary. Remember, when you go to say puberty, physical changes, just use the 3 axes. If you go by pathophysiology, the 3 axes, you can get your symptoms. Adrenarche, gonadalgia, growth hormone. Say all these things, okay? If you go by steps, these 3 axes, you already have your things. Now, growth hormone, one last thing. We said that the girls are the dotted ones, okay? You see that the girls, they start younger to grow, but they have a lower peak. So remember 2 things. Girls have earlier onset, and the peak is shorter than the boys, okay? Boys have higher peak. The boys, higher peak 1 year later, okay? So maybe if you draw this graph and you show it to Honzik, you say, look, I know that the peak is lower, and it happens 1 year earlier. So this graph shows the 2 points. Boys higher peak 1 year later, girls lower peak 1 year earlier. Okay. This equation you need to know. I know it looks confusing, but this is how they like to write it. They like to write father minus something plus mother or mother. But if you look at it like algebraic, it's basically father and mother plus minus 13 divided by 2, then you add this, okay? So what does the equation mean? It means that who do you expect to be taller with the same parents? Okay, same parents, brother, sister. You expect the girl to be taller or the boy? The son, the boy. So if it's a boy, add plus 13, okay? When you see a boy, plus 13, because we expect them to be taller. When you see a girl, same parents, minus 13, because you expect them to be shorter. So if you do this calculation here, you're going to find something called predicted adult height or mid-parental height, because we use the parents to find what the genetics should be. So this is just genetics, okay? If you do the equation, you will find only one number. If you do this equation, you find one number, right? So your calculated number should be this one. But this means that we can exactly determine your adult height, which is impossible, right? We need to have some range. So after you find this calculated number, you add 8.5 and you remove 8.5 to find the 3rd centile and the 97th centile. So it means that for your gender, man, which we did the plus 13, with the same parents' height, they should be this range. They should be adults in this range, okay? So if I have the same parents and I have 3 sons, they will not all 3 be the exact same height, right? There's some variability. Even though we have the same parents, we have 3 sons. Some of them are tall, some of them are short. So that's why we need a range. Not a calculated number from the equation, but add and remove 8.5 centimeters. You understand this graph? If it's a female, you're gonna do minus 13. Okay, so it will be a bit smaller. So that's your calculation for height, and you need to know this for your state exam. Okay, how to explain it. Honzik specifically likes to explain it. Other changes, anthropometry, some organs changes, but what Zeman likes to ask is myopia. Okay, he likes to ask myopia because axial growth of the eye, because growth hormone, whatever, okay, makes the eye. So myopia is what Zeman likes to ask. So physical changes, bone age. Did we talk about bone age? What does it mean, bone age? Okay, so we have a way of calculating the age of your skeleton based on left hand X-ray. Okay, why left hand? Because we try to make it standardized. Okay, we have a right hand, left hand. There's some variations. Like we said, look, we try to make it as standardized as possible. Let's always use X-ray of the left hand, metacarpals and carpals. Okay, you take the X-ray, then you have a book, and in the book there is for the same bone, there is different images of how it should ossify, and it tells you if it's ossified at this stage, this bone is this age, and then you make a score for all the bones. You make an average, and you find the skeleton of the baby, how old it should be. This is important for pathology of puberty. Okay, if you see someone who didn't enter puberty, is delayed, and you're like, come on, like let's see, is there some pathology, or is he going to mature eventually? If it's physiology and he has some slowdown, but then he matures eventually, we call them late bloomers. Okay, you know, bloom of the flower, blooming, it means that it's going to grow. So eventually it's going to bloom, right? Eventually he will reach the predetermined height, but at the moment he's late. So that's why it's late bloomer. And you can see here a late bloomer. He was normal at birth, then he started to slow down, but then he catch up and he finish on time. Okay, so what I'm going to do at this point here, I have only this information. It's going, and then slowing down. At this point in time, I have no idea what's going to happen in the future, right? I'm at this point. I'm going to take the skeleton, okay? And in the skeleton, I'm going to find the age of the skeleton. And I'm going to say, look, this guy, he is 15 years old, but his skeleton is actually 10. So he's not ossified yet. So he has potential to grow. Okay. So we have to look at the bone age to know if there is potential to grow or if the bone is getting ossified and then this child is not able to grow. It's very important to achieve the adult potential, okay? One of the things we're worried about as endocrinologists in pediatrics is to have long-term effects for quality of life, and terminal height is one important factor, okay? You see people who are short and they have some complex or whatever. We try to make them, treat them to achieve their potential, height potential, okay? So it's very important. This is, again, a revision for what male happens. First sign is testes volume enlargement. Do you know what is Prader orchidometer? Have you ever seen one? Prader orchidometer? Okay, so basically this is balls. Okay, it's your testicles. And the first three are always pre-puberty. And we color them dark blue or something. It's different color. And the rest are puberty. Okay? So you put it next to the testicle and you look how much volume it is, how big the testicle is. Okay? So with this, you can know how much ml is the testis. Pre-puberty should be 1 to 3. Adults should be 15 to 25. Okay? That's how you measure the volume of the testis. Okay, we spoke about all of these things. And then for females, we said first sign, remember, breast and growth. Okay, these two things. Everything else we talked about it already. Okay, how do last part of the lecture? This is how to assess the secondary sexual characteristics. So someone comes to you, he's like, look, I'm undergoing puberty. I don't know where I am. Am I at the beginning? Am I at the end? Am I in the middle? So we need to have a standardized way to know where are you in this puberty change. Are you in the beginning, middle, end? Okay, do you know what stage, like which scale we use? What? You're right, yes. It's called Tanner, okay? So Tanner scale. The easiest way to do it, use your hand, remember? 5 things, always 5 things. The easiest way to do, just the way I memorized it, because it's a bit too complicated. First is pre-puberty. Last is adult, okay? It makes sense. If you know that you start from a child, pre-puberty, and you end up as an adult, that's 2 points down. You only have to memorize 3, okay? So it's making everything easier. There is 3 parts in this Tanner scale. The first one is in both males and females. That's your adrenals, yes? So that's pubic hair, because both males and females have pubic hair, and that's your adrenals, your adrenal hair. The second part of Tanner scale is the first sign of puberty. So what is the first sign of puberty in females? Breast and growth, okay? But now for Tanner scale, we don't care for growth because that's a different hormone. We care for gonadal hair, so that's breast. So female is breast. So you will do M, mammary, not in boys, but in females. And then the onset of puberty in males is testis, yes? So that's your genitals. You will only do it in males, okay? So first sign of puberty in males and females, that's 1 for each, plus pubic hair for both, you end up with 2 for each gender. Pubic mammary, pubic testicles or genitals, okay? So adrenal hair for both of them. Adult, pre-puberty, number 1 and 5, okay? Then the easiest way to do is if you go to number 4, is the same as adult without the thigh. So you just say adult without the thigh. That's 4 done. You understand? You see that the adults should have a bit hair on the thigh. You see it? You see there's a bit hair there? Number 4 is the same as adult, but without the thigh. Okay, done. And then you have number 2 and 3. We know that number 3, it means we have some dark hair until syphilis. So that's up. And then we have number 2, which is, okay, it's beginning to become pigmented at the root of the penis or at the root of labia. So that's down. Okay, down and up. Up, pubic syphilis, down, root of penis or root of labia. So the way to memorize, very easy. For the P, we start number 1, pre-puberty. Number 5, adult. Number 4, adult without the thighs. Number 2, root of the penis or labia. And number 3, symphysis. Okay, so the symphysis is the line over here, this line. Okay, that's very easy to memorize. Already memorized it. Very easy. You just review it a few times, you will never forget it. Then we go to the second one. We said females, they have the breast. Again, easier way to do it. Number 1, pre-puberty. Number 5, adult. Then number 4, it's called secondary mount. Okay, what does it mean? It's like there is 2 mountains. If you see the blue line and the pink line, it's like they're not meeting each other. They're making 2 different mountains. Okay, so that's your nipple and areola. They grow at a different height than your breast, which causes to have a shape of 2 mountains, blue mountain, pink mountain. Okay, so again, pre-puberty, adult, secondary mount. And before we did up and down for the pubic hair, for breast, I'm doing behind and away. So it's like behind the breast and away of the breast. They become enlarged, as you can see from the picture. Okay, so again, the same logic with pubic hair. That's how I memorize this one. Very easy to memorize. If you do it a few times with your hand, you will remember it forever. Easy way. Okay, this is what Zeman likes to ask. He says that men like big breasts. Why? Is it because their subconscious was programmed due to A, internal and external factors of what is beautiful, like social media, magazines, or what your friends say? Or is it B, years and years of natural evolution, because bigger breasts have better chances for newborn nutrition and survival, so the baby will become stronger and he has better chances for survival, and natural evolution, finally, subconsciously, the men know that big breast is the way to go for their child to be successful. Is it A or B? B? Who says B? Raise hands. Who says A? Okay, so the girls here are right. It's actually A. Remember that the breast size has nothing to do with nutrition, okay? Nothing to do. Who decides the nutrition of the breast? Who controls the nutrition of the breast? Prolactin, okay, that's secretion. Okay, so Aditya is saying the mother. Basically, okay, that's a mechanism, that's a pathway. What I wanted to hear was the baby, okay? Imagine the baby has fever, okay? It's having some fever. It's going to cry in a specific way. It's going to give a specific, okay, another question. When does communication in the pediatrics start? When can the child start to communicate with the mother? How old is the child when it is able to communicate to the mother? Baby in here. Yeah, what? Okay, so age, when? 1 month, 2 months, 1 year? 1 month, so 1 year. So you're saying that for 1 month, the baby has no way to tell the mother what is at birth. Aditya is right. So Aditya is right at birth, okay? Since birth, the baby can talk with the mother and communicate. So that's why the baby is able to control the breast milk, the nutrition. If there is fever, it's dehydrating from sweat. It tells the mom, look, mom, I want some more milk. I'm dehydrating, okay? So the baby is controlling it. And then we have the last part of Tanner scale. That's your male first sign. That's your gonads. We spoke about gonadal orchidometer. So that's pre-puberty, adult. Then you have number 2 is testes and scrotum, and largest and thickens. And number 3 and 4 is length of penis and then width of penis, okay? Length is first, width is second, okay? There is some other ways to describe genitals in a Tanner scale, but I found that this was the easiest way for me to memorize, okay? Some people can also learn the ml or the length of the testes or the hair and how it looks like, but I use this one. I thought it was the easiest way to learn. And a quick revision. So that's our last revision. Growth, it happens since onset of puberty in females. So breast and growth should happen during onset. Yes, first sign of puberty in females. Growth rate and breast, okay? Then we have peak onset of growth. And then 1 year later, we have the menarche. Okay, same with the boys. The boys, as you can see, it's not during the growth onset is not during the onset of puberty. The first sign is testes. Growth starts 1 year after than females. As you can see, the growth is 1 year after than females. And then the first ejaculation is 1 year after the peak growth. Okay, it's not written here, but it should be here. 1 year after peak growth in boys, it should be the first ejaculation. Then you have pubic, same, and the genitals is together with the testes and genitals. Okay, so that's like a revision summary of the Czech puberty. So this is adolescence. I don't know, should we do adolescence or should we finish? Okay, so we should leave the lecture here. Next time we're going to do the pathology of adolescence. Okay, because adolescence is, we said CNS, which is the behavior, and in Czech Republic it's called sociopathologic phenomena. Okay, so there is a question called risky behavior in adolescence, and you know, when you see someone who has mental retardation, you don't say he's mentally retarded. You can say like it's more handicapped in the law. You know, you use some softer terminology in the law. So when you have someone with high risk behavior, in the Czech law, it's called sociopathological phenomena. And we will talk about it on the next lecture. And so that was the physiology of puberty. Now we will talk about physiology of adolescence and pathology of adolescence. Okay, so let's leave it here. Any questions online or any questions here about puberty and physical changes and physiological changes? You learned today how to calculate gestational age. Yes, how to classify them. Pediatrics and obstetrics. What is the difference? The 3 axes involved in puberty: adrenarche, gonadarche, and growth hormone. Okay, and you learn that important is that we have pattern as well in endocrinology. Not just the value, but also the pattern is important. And by changing the pattern, we can suppress something or activate it. Okay, okay, that's good. Dynamic testing. Thank you, sir. Okay, Aditya, no questions from Aditya. Any questions from you? No? Okay, so yeah, see you on next week or next lesson. See you. Did you learn,